Uh, we are now live, and we welcome you all to annual office practice CME organized by Institute of Child Health, Kolkata. Today we'll discuss some cases about pediatric endocrinology. Our first speaker is Dr. Sumona Kundagrami, and she is assistant professor in pediatrics, Ramakrishna Mission Seva Pratishthan. She is very active and enthusiastic. And over to you, Dr. Sumona.
Good evening, everybody. Thank you very much, Viday, for that nice introduction. And thank you, ICH, for inviting me to speak. It's always a pleasure, honor to speak in the forum of ICH, which is the academic hub of Kolkata. I'm honored, privileged, and excited and nervous at the same time. My topic for today is a sad one, though, children who didn't grow. But I'm here to share my learning experience and what little I have learned over the last few years during my journey to be a better pediatrician, a better version of myself. Actually, I must say at the outset that I'm no pediatric endocrinologist. I'm just an ordinary pediatrician, and these are all my learning experiences. I still consider myself a student only. Thank you very much once again. So let's start. So introduction and the learning objectives. So we know that growth failure is mostly physiological, and only 20% of the children need actual evaluation. And the final height is grossly determined by genetics with 60 to 80% variation, with interaction of nutrition factors, mostly in the under 2 age group, and primarily endocrine factors over the 2-year-olds, in the more than 2-year-old. And our aim as pediatricians should always be to avoid unnecessary investigations while not missing the real pathological ones. Now, the tools, what do we need in an OPD setting where these children are referred to us? So first we need a proper stadiometer, and the child should be standing with the face in the Frankfurt plane with the feet close together, and then we have to get a proper height and plot it on the IAP charts, the age and sex appropriate IAP charts, which are very recent and validated and are excellent tools. We should have the weighing scale, and we should get this bone age X-ray, the left hand and wrist X-ray. And also I have shown the picture of an orchidometer, which indicates we need to assess the pubertal status of those nearing puberty. And this is by which we measure the testicular volume of the boys. Now, classification. How do we classify? Based on height. So if the child is more than 3rd centile, it is not a case of short stature anyway. We can reassure the parents and without doing any unnecessary investigation. If the child's height is between 1st and 3rd centile, they definitely need follow-up. And if they're definitely less than 1st centile, these children are definitely for workup. And we have to now see whether they're dysmorphic. If there is dysmorphism, then they can be syndromic. If they are not, they don't have any dysmorphism, then we look at the weight and calculate the weightage. I'll come to the later slides where I'll say how to calculate the heightage and weightage. And now, with the relationship between heightage and weightage, we will be able to come to a rough estimation as to whether these are to find out the cause of the short stature. So if the weightage is seen to be more affected than the heightage, then we will think about causes like infections, celiac disease, and or maybe renal tubular acidosis. If the height is more affected, so heightage less than weightage, then we would think of proper endocrine causes like hypothyroidism, growth hormone deficiency, or maybe Turner syndrome, to name a few. So the approach. So we have to first confirm that it is definitely a case of short stature. So now, if we see that it's a short stature case, then we have to see whether it is a case of physiological short stature or a case of pathological short stature. By physiological, we have 2 entities, the most common being CDGP, or the constitutional delay of growth and puberty, and the familial short stature. Often we get a lot of referrals from parents where they are anxious about the child's growth, and we just have to do the formal basic evaluation and maybe reassure them without doing, again, any further unnecessary investigations. If we think that it is really a case of pathological short stature, then we have to think of two categories. If it is primary, by primary women, the disease condition is at the growth plate only. The causes being skeletal dysplasia, or in cases of small for gestational age child, or genetic causes of short stature. Whereas the secondary causes of short stature mean the environment is at fault. For example, either it is a nutritional problem, like in case of systemic infection, malnourished child, or celiac disease, or it could be again endocrine, like hypothyroidism, growth hormone deficiency, and Turner syndrome. So as pediatricians, you see, it's a very fine balance. So we have to balance the two. Without doing any unnecessary investigation, we have to find out the real pathological cases. So approach to a case of short stature. I'll just go through a very basic few slides without going into too much of details, because I know you all probably know by now all these, and the history, as we all know, is very, very important for any approach. So we have to take a detailed history, not to miss the following ones: birth history, the weight, the gestational age of the child, whether it was a breech delivery, because breech has been found to be associated with multiple pituitary hormone deficiencies, neonatal hypoglycemia, again indicating growth hormone deficiencies. Family history, especially consanguinity, is very important. Then markers of any chronic disease like polyuria, etc. The developmental history of the child, any history of hospitalization earlier, any drug or medicine that the child may be taking, and of course, the onset. When did the parents first notice that a child looked short, or since when has the growth been faltering? How much is the child shorter than the peers, etc. Moving on to the clinical examination, the faces, as we start from head to toe, faces. So if there is any dysmorphism, as we discussed earlier, it could be a case of genetic short stature. Now, anemia, for example, in celiac disease, we can find anemia, jaundice in case of any chronic liver failure, cyanosis in case of heart diseases, and lymphedema is a very important marker in case of Turner syndrome. We must not miss it. And a detailed systemic examination to rule out any chronic diseases. And then there are specific pointers like wide carrying angle, or shielded chest, or webbing of neck in case of Turner's. A short foot metacarpal can be seen in either Turner's or pseudo-hypoparathyroidism. And then optic disc should not be missed, especially in case of septo-optic dysplasia, where optic nerve hypoplasia can be seen. Now, again, what to assess? So height, accurate measurement of height and plotting on the chart, accurate measurement of the weight and plotting on the chart, calculation of height, age, and weightage. At least this much should be done by pediatricians. Height SDS are usually done by endocrinologists. And then USLS ratio to find out whether it's a case of proportionate or disproportionate short stature. And then, of course, we should not forget bone age, and, of course, pubertal status, because puberty and growth go hand in hand. Now, what are the information we can get from a growth chart? These are not very accurate, but I've just tried to show you. For example, a child comes to us with short stature. Let us assume that he is a kind of 14-and-a-half-year-old boy, and his weight is here as pointed, and then his weight is somewhere here. So when we draw a straight line onto the 50th centile curve and drop a perpendicular, the height it is coming to somewhere 9.5 years. And if we do the same with the weight, the current weight, then the weight it is coming to be something around 13.5 years. So see, the height is way more affected than the weight here. Okay, so definitely this is not a case of any physiological short stature. Also, so one is plotting of the height and see where the child stands, plotting of the weight, then calculating the height, dropping the lines and finding out the heightage and weightage, and also to see the familial expectation and the potential, and to see whether the child is short for the family as well. So you see, we know that how to calculate the mid-parental height. For boys, it would be father's height plus mother's height plus 6.5. And for girls, it would be subtracting 6.5 from the father's plus mother's height by, so the subtraction is for the girls and the addition is for the boys. And then we calculate the range by plus minus 6 centimeter. And then we draw parallel lines and then see clearly in this case that the point is definitely below even the family potential. So this is a typical case of pathological short stature. So when to evaluate and refer? So the three broad categories are, as I told, if the child is very short with the height SDS being below -3, if the child is short and not growing, Okay, the height SDS being -2 to -3, and the growth velocity SDS below -1, or the child is not growing at all. So it may be the case that the child was initially okay, as you can see here, but then if we follow them up over a period of time, we can see that the child has actually started faltering, crossing 2 major centiles. So in this case also, this child needs evaluation and referral. Now I'll take you through few cases which I have been a part of, or I have seen, I have learned from these. Some of these may be apparently simple, or some are very enigmatic, some are weird and wonderful, but each one has a message for us. And through these cases, I'm trying to show the approach of any child with this kind of children with short stature. And I'll try to show the spectrum of cases that we normally get in our OPD. So the first case is a 2-year, 7-month-old boy who comes to us with failure to thrive, the weight being 8.25 kilos below 3rd centile, height being 84 centimeter below 3rd centile, height SDS is -2. So weight, and we said found out that the weight age was more affected than the height age, but still this child, the parents were anxious. These are the child was born out of consanguineous marriage, a full-term baby, low birth weight, and then there was very improper weaning. The child was fed with milk up till 1.5 years, but there was no history of hospitalization. So what to do with this child? So we run a battery of tests, the basic ones, and we find out the child has mild anemia, low CPK, probably because of the low muscle mass, thyroid function test, renal function test, blood gas, LFT, vitamin D, calcium, phosphorus, everything was within normal limits. Although initially the postgraduates were thinking, could it be a case of rickets? But then nothing, it was not really suggestive. We also did the celiac screen, but the anti-TTG, IgA and IgG both came as negative. However, the anti-gliadin antibody, which was a part of the panel anyway in the laboratory, came to be strongly positive. Now, we got confused. I don't know what the audience has to say in this regard, but I have specifically put this case for discussion because, see here, the child needed evaluation because the height was less than 3rd centile and it was -2 standard deviation. So the borderline case, the weight was affected, parents were anxious. But the things are that we should not go for fancy any endocrinological tests right now, because before doing all that, we should first exclude all the commoner causes like celiac. So what we have done, since we cannot label this case as a potential celiac unless we get a biopsy done or the opinion from a pediatric gastroenterologist, we have referred the child to a pediatric gastroenterologist. But the message from this case is, and there were nutritional factors and malabsorption too going on probably, but so we will follow the child up. We will not stamp the case as a case of celiac disease, neither should we go for any fancy test, but we should just follow the child up and see what the time has in store for us. Moving on to the second case, a 10-year-old girl who has been coming to our OPD for a number of times with growth failure, height was way less than 3rd centile, weight less than 10th centile, had a high TSH, around 20. So she was on thyroxine supplementation. And then the follow-up showed that the child was not really growing despite normalization of TSH with thyroxine supplementation. There was no issue with compliance whatsoever. But suddenly one day, on closer look, a very wise and observant pediatrician found out that the child had a short 4th metacarpal, which was not noticed for so long. The celiac screen was normal. So what do you think the case had? Any thoughts? See, the karyotype was sent then, and then it came back as a case of Turner syndrome. So the learning point from the case 2 would be hypothyroidism is a common association of Turner syndrome. Poor growth despite thyroxine supplementation should prompt us to look for other causes of growth failure. And any short girl who comes to our OPD should have a karyotype done to exclude Turners. Moving on to case 3. So one day I was sitting in the OPD, the pediatric and the endocrinology OPD, and this girl, a very depressed looking, puffy faced 18-year female came to me with her aunt. And I don't know whether she found me friendly or not, but she started crying. She had a dream of a nice life, but the problem was she hadn't started periods yet. She was very short. She was just 139 centimeter, weight was 31 kilos, height age being 10 years, weight age 10.5. Can you imagine 18-year-old girl with a height age of 10 years, weight age 10.5, and nothing has been done so far. The parents were sitting at home doing nothing, and I don't know what the doctors were doing, but it was very sad to see that girl crying. However, there was no past history of hospitalization. So we saw the BP, which was on a lower side, and the other investigations showed that CVC was normal, FT4 was low, so was the TSH. TSH should have been higher, much higher compared to corroborating with the FT4 because they have a log linear relationship, but it was not. And the cortisol was low too, IGF-1 was low, LH, FSH, everything was on the lower side. And the MRI brain, which was already asked by the gynecological department, because the child had actually come to the gynae people with primary amenorrhea, they had ordered an MRI. The MRI showed a small hypoplastic pituitary there with ectopic posterior pituitary. You can see in the image, I don't know, yeah, let me see there. So what was the case? It was a case of multiple pituitary hormone deficiency presenting so late at the age of 18 years. Can you imagine? Thankfully, there was no crisis, but it could have happened any time. Who knows? And but we must remember that now we got all the hormones as low, and we could easily label it as a case of MPHD. However, they usually can present over a period of time in phases. So initially, for example, the growth hormone can be low, then the LH-FSH will be low, then the thyroid will be affected, and finally maybe the ACTH will come. The report will show us indicating MPHD. So we should be following up these children, doing repeated hormone assays to find out. And then we sent the child back home with supplements of different hormones, and we will follow the child up. Estradiol has been added, and progesterone will be added later on. And hopefully within the next 2 years, the child would probably start periods. The next case is the weird and wonderful one. So this is the younger of the two siblings who came. The girl came with a large head, frontal and occipital bossing, hypertelorism, big nose, high arched palate, short fingers and toes. So clearly dysmorphic with disproportionate features. Her anthropometry showed a height of 96 centimeter, less than 3rd centile, weight 16 kilo, 10 to 58th centile, arm span 93, upper segment, lower segment ratio is 0.95. So clearly disproportionate. And then the left hand X-ray was ordered. So bone age was equal to the chronological age, that is 4 years, but that was more than the height. So height is again very, very badly affected. However, the systemic exam was within normal limits. If you look at the X-ray, one thing is striking. The bones are looking really dense, you see. We were thinking, could it be a case of osteopetrosis? But then the systemic exam was completely normal. There was no anemia. We were very confused. And then the wise endocrinologist found out that this phalanx had a distal resorption. You can see here, this acro-osteolysis. And this was a eureka moment for us. We went out to do a skeletal survey, and all the bones looked very, very sclerotic and dense, as you can see. The skull bone showed an open fontanelle, and then the acro-osteolysis that I was talking about. Any guesses? So we sent the whole exome sequencing to SGPGI Lucknow, and the report came back as the mutation, the frame shift and a missense mutation of CTSK gene, making the diagnosis for us as Pycnodisostosis. I don't know whether you've heard about it, but this is a rare autosomal recessive disorder. First, I think it was the French impressionist painter, Henri de Lautrec was, I think, affected. And this is a very rare case. And then whereby the osteoclasts are very defective. And so the bones are usually very dense with an increased risk of fracture. So this was a genetic case of short stature. Pycnodisostosis was a diagnosis. Moving on to next cases, so 2 siblings, 16 years and 10 years. Can you imagine these 2 children? Do they look like 16 and 10? They look really younger, and they're definitely short, but they look younger. They have the typical, the younger looking faces with frontal bossing. For confidentiality reasons, I have to, cover the eyes, but if you can appreciate their sparse hair, frontal bossing, the chubby cheeks and shallow orbit the children had. So these were the two siblings. Height SDs for both were around -4.6 to -5. So definitely extremely pathological, really, really low. And height age was less than the weight age, less than the bone age, which was less than the chronological age. So we ran the battery of tests as usual, and the thyroid and cortisol all came back as normal. However, the IGF-1 for both came back as very low, 50 and 67. And the MRI brain for both showed hypoplastic pituitary. And the post-clonidine growth hormone levels were all very, very low. They were all below like 5 nanograms per mil. So I think the diagnosis is quite clear to you now. This was the case of growth hormone, familial isolated growth hormone deficiency type 1A. So I want to stress here that family history is very important. Actually, the youngest sibling was brought to us, and then on history taking, the family did say that the older sibling was also affected. So I don't know, these children are lost to follow up, unfortunately, but I heard that they got the GH for at least 2 years, and they did better on GH therapy. So the last case, it's a 13-year-old girl of Sojia, maybe one of Priyanka Das, patients on steroids and DMARDs. On examination, showed Cushingoid habitus, and the weight was 22 kilos, weight age being 7.5 years, height was 118 centimeter, height age being 6.5 years. So we can see height more affected than the weight, and the child was clearly prepubertal with SMR being B1, P1. This is very obvious and clear case of Cushing syndrome. So the height was affected probably due to both the main disease, the Sojia, and as well as the prolonged steroid use. So the lesson from this case would be any child of any chronic disease on steroids need to have the growth monitored carefully. So to summarize, we should plot height and weight on age and sex appropriate IP growth charts for every child who comes to us, not only those who come to us with short stature complaint. Okay, it's always a good practice, and if you want to be better pediatricians, I think I would request all, especially my postgraduate students, to please plot both height and weight on the IP charts from now on. Follow up the child and measure height velocity, because height velocity is considered to be one of the vital signs like heart rate, respiratory rate, and take a detailed history, because the history is very, very important. Detailed examination is also very important, and read the investigation sent thoroughly. Because often we do that, the investigations are sent and ordered, and then we don't have the time to go through them properly, and we often can't come to a proper diagnosis. We should read x-rays thoroughly, try and learn the interpretation of bone age from the x-rays, and we should definitely refer to the pediatric endocrinologist experts if we are not happy with the child's growth, because we know that the reversible causes will definitely improve. The iatrogenic ones like Cushing's will also get better once the steroids are stopped, and others also can do much better with treatment. At least they can have a better quality of life. So this is the least we can do for them, isn't it? So I think I would end my presentation here. Thank you very much for a patient hearing. And I don't know whether you watched this movie, but this is a clip from the very famous award-winning movie of Kaushik Ganguly, Choto De Chobi. And this deal with the pituitary dwarfs. You know, they might be entertaining us with their smiling faces, but deep underneath, they have that agony and pain of, that they're so small, compared to their the population mean. And so I know that height should not be a limiting factor for anything, for dreaming and all, but anyway, when they come to us, we should do our bit and we should try and help them. Thank you so much. Thank you.
Thank you, Sumonadeep. Thanks for your very excellent presentations about short stature cases. I think we will take the questions at the end of our session.
Okay.
And please stop sharing up your screen, yes, and I will start my presentation.
Just a minute. How can I stop the sharing? Sorry. On
top of your.
Just a minute. Top of my.
I think I am sharing my screen now.
Okay. Okay.
Is my screen is visible?
Yes, yes, দেখা যাচ্ছে.
Okay, thanks. So, good evening, everyone. Today, I will just share my experience in pediatric endocrinology in last 1 year at ICH. I will not discuss about any particular topic. I will just go through some cases. I will not discuss about details of those cases. So this is Lina Medina. She gave birth to a male healthy baby when she was just 5 years, 7 months, and 11 days. She is still alive. She's 88-year-old now. This was possible only because she had precocious puberty. So this is a 5-year-old boy presented with precocious puberty. You can see that the penile size, testicular volume, and pubic hair all are in Tanner stage 3. Bone age was quite advanced, 9 year in Gulick-Pyle method and 9.3 in Tanner-Whitehouse method. LH, FSH, testosterone, all in pubertal ranges. And obviously 17 OHP, beta ECG, and thyroid function was normal. And we did an MRI, and you can see that there is a space occupying suprasellar lesion, most likely craniopharyngioma. So then we referred the case to neurosurgery people. Here also you can see a 7-year-old obese girl presented with precocious puberty and MRI shown huge arachnoid cyst. So in many guidelines, if a boy is coming with precocious puberty, you must do a MRI. If a girl is presenting at between age of 6 to 8 years, some guidelines says you can skip MRI, or you can just do MRI if she is having any clinical features suggesting any CNS problem. But I usually prefer to do a MRI in any cases of precocious puberty, because most of the time we can miss any CNS problems like this. So here 5-year 2-month-old girl presented with breast development, Tanner stage 2. There was no pubic hair, and you can see bone age was a little bit advanced, around 7 years, and other thyroid functions are normal, and LH, FSH, estradiol was in pre-pubertal value. MRI brain was normal. So we came to a diagnosis as premature telarchy, and then we are following up that patients. But in 1 year, the breast development progressed a lot, and you can appreciate that the height acceleration in growth chart, and this is the magic of plotting height in growth chart, and growth bone age was also advanced a lot, like around 9 years at the age of 6 years. And but the hormonal assays like LH, FSH, and estradiol are still in pre-pubertal range. So in this case, we should do GnRH stimulation test, and you can see the LH, FSH are in treatable range. So it is a case of idiopathic central precocious puberty, and GnRH analog therapy was started. So lesson from this case is, even a case of premature telarchy or premature adrenarchy, you should follow it up. You never know, it may turn into a true precocious puberty. In this case, 8-year-old girl with complaint of vaginal bleeding for last 7 days and not gaining height. You can see the dry skin, post-facial feces, and you can see the child is very short, and bone age was very delayed, 2 years in Gulick-Pyle method. This is the gonage picture. And on investigation, thyroid was, TSH was more than 100, T4 was low, and USG neck showed benign thyroid nodular goiter, and anti-TPO antibody was more than 1000 IU per ml. So this is a case of autoimmune thyroiditis, definitely. And so diagnosis is long-standing untreated hypothyroidism leading to precocious puberty and Van Wyk-Grunberg syndrome. So any girl, if presenting with precocious puberty and she is short and she had delayed bone age, I think you are pretty sure that this is a case of hypothyroidism even before running the thyroid function test. So short child, delayed bone age, precocious puberty, it is hypothyroidism. So in last 1 year, I had seen 28 cases of true precocious puberty, 9 of puberty variants like premature thelarchy and premature adrenarchy. Definitely girl is common, and idiopathic central precocious puberty was diagnosed in 22 cases, and rest are some few CNS tumors, some are hypothyroids. And so here a newborn Tom Elucius had repeated episodes of hypoglycemic seizures, so persistent low blood glucose even on GIR of 12 mg per kg per minute. So here we set the critical samples, and in critical samples, serum insulin level was very high, urine ketone was negative, and serum cortisol was also low. So actually, this was a case of hyperinsulinemic hypoglycemia. So if you ask about this low serum cortisol, sometimes due to prolonged hypoglycemia, some adrenal response to hypoglycemia is somewhat blunted, maybe some because of some other reasons, I don't know. But here it is not adrenal insufficiency. Definitely we have to follow it up and again run the serum cortisol later, but you don't have to treat this serum cortisol. This patient has hyperinsulinemic hypoglycemia. We started the patient on diazoxide, but even on diazoxide 15 mg per kg per day, there was no reduction in GIR, and repeated episodes of hypoglycemia, jitteriness, and seizure were there on even on diazoxide. So it is a diazoxide resistant hypoglycemia. The importance of it is like most of the cases of diazoxide resistant hypoglycemia, there is possible KATP channel mutation, and then you have to send genetic test very urgently, because many cases when the KATP channel mutation is from paternal mutation, then there is a high chance you can get a focal lesion in pancreas, and if you do pancreatectomy partial or subtotal, then these conditions are treatable. So you have to send genetic test, and we started an octreotide subcutaneously every 6 hourly. After that, the baby was maintaining normoglycemia, and genetic study showed ABCC8 mutation, and that proved the reason of this hyperinsulinemia. So here, a 3-month-old female baby born of consanguineous marriage presented to us with decreased activity, decreased feeding, and no weight gain. There was perinatal asphyxia, developmental delay, hypotonia. And this is the growth chart, which is showing the weight for age and height for age is all below the first centile. On investigation, blood glucose was low, TSH was low, FT4 was low, and serum cortisol was 6.5. ACTH was 15.2. So here we can see the low blood glucose obviously, and there is central hypothyroidism. But if you look into this cortisol level, the 6.5, even if it is within normal range, at the point of hypoglycemia, the cortisol level should be more or higher due to hypoglycemia stress response, but here it is absent. So the baby is also having some amount of adrenal insufficiency, likely central adrenal insufficiency. MRI brain showed the pituitary gland, some cystic changes. Posterior pituitary bright spot was there. Pituitary stalk was normal. So our diagnosis was multiple pituitary hormone deficiency, and we started treatment with hydrocortisone at first. Then we introduced levothyroxine. This MPHD and the cystic changes is in the pituitary. We don't know it is some due to genetic mutations, or it is due to the hypoxic ischemic encephalopathy, which is not that much common when HIE is affecting the pituitary gland. We had sent genetic study report is pending, and you can see during follow-up after around 3-4 months, the look of the child is way better. So this is a 5.5-year-old girl presented with the midline neck swelling, you can see, and this swelling moves with swallowing. And here TSH was high, definitely, and FT4 was low. And thyroid peroxidase antibody was also positive. So this is hypothyroidism, and sorry, anti-TPO TPO antibody was negative. And USG showed suggestive of ectopic thyroid gland, and we did some technetium scan, and you can see there was thyroid uptake in the swelling, and as well as there is a uptake in the lingual thyroid. So there is dual ectopic thyroid. So it is simple. This girl presented with bowing of legs and broadening of wrist, and definitely from X-ray you can see fraying, and this is nutritional recate. Vitamin D was very low. We treated with vitamin D, and you can see there is complete healing within 2 months. This girl presented with obesity and bowing of legs, and you can see this beaking up metaphysis and epiphysis of the tibia. So this is Blount disease. So sometimes obese child with bowing of leg can have this disease. This is an orthopedic conditions. You need orthopedic corrections. So a very common case here. Many times I got this kind of patients with obesity, and the parents had concern about small penis. So some doctor ran had did this hormonal assays, LH, FSH, testosterone, all were low, and injection testosterone was prescribed by some doctor. But when I measured the SPL, stretch penile length, it was 5.8 centimeter, which is within the normal range, and also that minus 2.5 standard deviation at this age was 3.8 centimeter, Tanner stage 1, and bone age 8 year 10 months. So it is a case of body penis. So measure stretch penile length first before diagnosing in case of micropenis or before giving any hormonal injections. Compare with reference range. I usually use this reference range. This is from Harriet Lane handbook. There are many reference ranges available online or some books. Also, there is some Indian reference ranges, some reference ranges from our state also. And then do Tanner staging. And at the max, you can do bonus that can give some clues about if it is delayed or not. So don't jump into giving injection testosterone just by measuring, just by seeing the patient and even not measuring that penile length, because it may be buried penis. So it is an interesting case. A 5-year-old girl, obesity and very rapid weight gain of 16 kg in 3 months. She had self-mutilating behaviors like biting his tongues, biting his lips and fingers. She had voracious appetite. She had lateral deviation of left eye, squint, sleep disturbances, behavioral changes, and breast development. You can see the picture. She just injured herself by biting her fingers, lips, and tongues. I couldn't show the eyes here, but there was lateral deviation of left eye. And you can see just before 3 months, the girl was like this, such lean and thin and beautiful. And this is the bone age was 6 year 10 month, little advanced. Blood pressure was on little higher side, 130/80. Heart rate was 134. And weight and height, you can see the BMI was way above the obesity range. So our provisional diagnosis was Spruvage syndrome, that is rapid onset obesity with hypothalamic dysfunction, hypoventilation, and autonomic dysfunctions. Only 100 cases were reported worldwide till now, so our case may be 101. And these are the clinical features which we can see in Rohat syndrome, but there is no definite diagnostic tests to diagnose Rohat syndrome. You just have to rule out many things. Here we can see that there was central hypothyroidism, and we started on levothyroxine. Her blood pressure and heart rate was on higher side, so we sent 24-hour urine catecholamine, and normetanephrine and VMA was high. MRI brain was normal. We did MRI of chest and spine. You can see there is a space occupying lesion, paravertebral mass. So this is a case of Rohat net syndrome, Rohat associated with neuroendocrine tumor. And we arranged surgery. You can see the tumor here, and we sent it for HPE. And HPE, so stroma poor neuroblastoma and poorly differentiated subtype with an intermediate MKI, a very poor prognosis for this kind of neuroblastoma. And most of the time, the reported cases in Rohat, there is paraganglioma or ganglioneuroma, like this kind of neuroendocrine tumor. Neuroblastoma is not very common in Rohat syndrome, but it's still a evolving disease, so we don't know what will happen. So this is the data in last 2 years from my 1 year in Gangaram and last 1 year in IC. We got around 800 obese child, and surprisingly, you can see that 21%, 21 to 22% had metabolic syndrome. And you can see a very good amount of patient has a non-alcoholic fatty liver disease, steatohepatitis, around 29% of cases. So definitely we should screen the obese child for metabolic syndrome and fatty liver. This fatty liver is reversible if you are losing your weight. So here a 10-year-old boy presented with severe DKA. See, he had an ulcer over his buttock and a swelling of both hands. So we did USG Doppler, and it showed long segment thrombus in cephalic vein in both forearm and proximal part of left basilic vein and left dorsal superficial venous arch. So we start on LMWH, low molecular weight heparin. So as you know that diabetes is a hypercoagulable state, and even during severe decay, due to dehydration, there you may come across this kind of thrombosis, deep vein thrombosis, and ulcers. So in last 1 year, I got 92 patients of type of diabetes. Among them, 3 had type 2 diabetes, and 63 previously old diabetes patient, and new onset diabetes. I had seen 26 patients, and 21 among them presented with DKA. Mean HbA1c during diagnosis was 13.2, and 2% had associated celiac disease, and 8 had hypothyroidism. It may happen. You have to screen in a patient of type 1 diabetes as it is an autoimmune disease, and you can have other autoimmune diseases too. So thank you, and Shubho Deepavali to all. And now we can, I think, go to the question answers. I think there was a question of bone age. Sumanadi, you want to, you just answered this
Just a
question.
minute, yeah, let me open the chat box. Can you tell me the question, Hriday, please? Because I have answered Dr. Paul privately, I
Which
think.
bone and what to look for? You had answered this by typing.
Yes,
You can,
just let me tell. Let me tell that because I didn't want to talk about the pretty overt ones like achondroplasia or the skeletal dysplasias because these are pretty overt in their presentation. Also, the physiological causes of short stature like familial and the CDGP. I chose not to discuss those and rather go on to the cases because you see, although they are very common referrals. So for familial, the one or both parents would be short, and initially there will be early growth failure, but they would maintain that the curve parallel, within that range of the familial potential, and then end up having slightly less height than the population mean. And for CDGP, which is the diagnosis of exclusion, is that initially the children would start off well, and then somewhere between during mid childhood at around say 7 years or so, they would start faltering and they would go shorter compared to their peers. And then again, so with the delayed puberty, of course, with anxious parents and all, and then again eventually slowly they would progress, the puberty would progress, and then eventually they would have normal height. But there's an overlap between the two as well. So that is for familial and the constitutional question. And for bone age, we usually by convention we do the left hand and the wrist x-ray in full extension with everything, proper exposure, everything should be visible. And like the non-dominant hand, to be very to be precise. And earlier there were lots of atlases and charts which we don't follow these days. So we have Bone Expert, a very highly paid expensive software, but then I use the Mediclasses application, the app, where it's created by Dr. Anurag Vajpayee sir, which is available on the Google Play Store. And this is really easy. They look at 5 sites. Earlier, we used to think that the carpal bones were the most important, but rather radius, ulna, and the metacarpals and their relationship between the phalanges is very important. And you can just go through the images, and then they will give you the range, the bone age. Almost accurate. It's a validated app, and it's pretty accurate. So yes, that's about the bone age. Anything else?
I think there is another question for me. If there is any role of junk foods and hormone-like substance used in
Sorry, I
causing puberty, I don't think so, because there is no data till now or any proof for that. But definitely environmental factor may have some role in causing early puberty in today's era. But I don't know about this hormone or hormone-like substance in this area.
Anything else?
Not no anything questions. Sir, are you there?
Yes, I'm there. I'm very much there.
Okay, sir.
But it was an excellent case. I mean, all the cases were very, very nice. About Sumona's case, I have seen 3 Pycnodisostosis in my life. So it's very interesting to see. And I mean, though it is rare, but in many of the picture books in MRCP-CH exam, they have these cases.
Yes,
Especially their pits are very classic of pycnodisostosis. And one comment about Rohad is that it's more of a Rohad-Net syndrome rather than Rohad syndrome, because it is associated with neuroectodermal tumors sometimes. And in fact, our case is not really Rohad rather than Rohad-Net syndrome. And one comment about early menstruation is also McQueen-Albert syndrome. So one should have, other than the Van Wyck-Grumbeck syndrome, one should also think of McQueen-Albert syndrome, because I remember way back in 30 years back, I had a patient of, which I still show sometimes at the pictures. The had a period of about 3 years of age, but it was your McQueen-Albright syndrome, and had a classic irregular spot.
So I had a question, what are the common complications of obesity in children? As per my experience, I think dyslipidemia, hypertension, and then you can get type 2 diabetes and
Metabolic.
metabolic syndromes, also obstructive sleep apnea, and also I had seen that obese girls tend to have puberty earlier, and they had some early breast development even within 5 years or 6 years. And if bone age is advanced, then we had to treat some of the obese childs also. So obesity also is related to puberty. Yes, sir. Continue. কি বলছিলেন?
আমি যেটা বলছিলাম is our environmental stimulation that you are talking of regarding the puberty. You see, most of the adopted children from this country to the Western country, they have an early puberty, isn't it?
Yeah, adoption is related to that.
Why?
Yes, adoption from Indian subcontinent or poorer country, when they reach the developed country, they have a early puberty. Now, factors may be operating, but maybe the environmental stimulations or others, we don't know. But that's a established fact that the early puberty can take place in adopted children. And any other comment I wanted to make? Yeah, I mean, one cause, though Sumana said that achondro is very obvious, but achondro is obvious, but not hypochondro and pseudoachondro. So we have cases, I think one of those child is getting growth hormone, Hriday?
Yes, sir. Yes.
But that's very experimental, isn't it, Hriday? The role of
It is experimental because it is only they are doing in Japan, I think, and Japan and Korea, and not in other countries. It is not an indications, but it is a trial method. And if you are seeing that there is a good response, you can continue, I think. And some of the achondroplasia may have growth hormone resistance also.
Yes.
So you may need some higher amount of doses. So that will make cause some, the glucose intolerance or this kind of thing. So you have to be cautious, but you can try if the parents want.
No, and we are also discussed with the parents first.
Yeah, yeah.
Yes.
The result may not be very good, and let us see what happens. And the parents agreed to that, and we started that. He started the therapy. So hypochondroplasia should be always kept in mind, not the achondro, but the hypochondro or pseudoachondro.
I thought I have to limit myself within 30 minutes maximum, so it would go. Otherwise, I would go on.
I know.
Also, I want to comment that 92 cases of diabetes, Hriday, in ICs, that's one. I mean, that's
so that includes the old previously diagnosed one, but newly diagnosed was 26, but also the previous and I think we have to open a diabetes clinic.
Yes, I think so. Yes. True.
Yes, because one of the main reason that one of the reason is that because we have a very sophisticated PICU, and we get a lot of cases from the PICU actually.
True, sir.
From the PICU, we get a lot of cases. So
we didn't get to see too many diabetics in our cane. So I was talking to Hriday about that. So that's very good that you're, I mean, not good for the children, but yes, I mean, but if they have a good referral center like ICH, then the children can get a lot of help.
No, the pediatric endocrinology in West Bengal is improving a lot, and we are proud of that. We are improving. We are improving. And any other comment about the short stature? Oh, the first case that you were showing, Shumona, I thought it is look like a Russell-Silver syndrome, but that's again a very important cause for short stature. And I have few cases of Russell-Silver syndrome, but now that Hriday is there, I'm not very organized in my life at all. So I think now Hriday, as I feel that he's very organized, so those cases of Russell-Silver syndrome should be included in the short statures. And what else? What else? Yeah. Hriday,
Yes.
one of the cases of precocious puberty, I mean, you started therapy slightly late. I mean, why did you wait for that? Because earlier,
Because at that time bone age was not that much advanced. It is around 1 year to 3 month advanced. And also at the time the basal LH, FSH and estradiol was on lower side. And at that age an MRI was normal at that time also. But at that 5 year or 5 to 6 year, you can wait for 5 6 months and follow up about the progression of the puberty to look for. And if you are getting a case of premature thelarchy, the bone age will not advance that in that pace, or the puberty you will not progress with that pace. So you have to follow up a few patients for some period before starting treatment. And also if during premature thelarchy, the predicted adult height, what we calculate through belly penu method and some other methods is there for Tanner Whitehouse. So if the predicted adult height is good, sometimes even the diagnosed case of precocious puberty, we don't have to treat. I mean, idiopathic precocious puberty, we don't have to treat all the time, because it's only the height related issue for the precocious puberty. If other thyroid and MRI, all things are normal.
that's a
So
major issue. That's a major issue because what is important is the height. You
yeah,
know, the rest of the things will be all right, definitely. But the major issue is the height. I mean,
yeah.
if I see a patient who is crossing 6 years, I
Mhm.
would rather start it early rather than to wait for some time. I don't know. That's my feeling is.
Yeah, because as the
Wait,
earlier you start, the benefit will be more.
wait 6 to 8, it's really very debatable that whether it really works or not.
Mhm.
And what else I was thinking, but it is an excellent case presentation. I mean, thanks to Genotropin for organizing this, and it's an excellent presentation. I think we should have more frequent and also sometimes a joint presentation with RKM
Yes.
Yes, sir, sure, definitely.
rather than sponsored by a company. We should have a joint presentation with RKM.
Thank you so much, sir.
Okay, sir. Okay, sir. So
Thank you.
good
Bye.
night. Good
Good night.
night.
Shubho Deepavali.
Shubhodaya.